Our area of focus in Eden Primary Care Network was around frailty and elderly health. The reason why we chose this was that when we looked at our population health figures to identify areas where there could be some concern about equity across the service, we discovered that 27% of our population are already over 65 years old. Looking forward 15 years, that was projected to grow to 40%. With a growing ageing patient population and a decreasing clinical workforce, this gave us real concern of how do we look after this very vulnerable, frail patient population to ensure that their needs are met and they are safe. With that objective, we created the Integrated Community Ageing Team, iCAT. This was a group of individuals working together for the benefits of the patient across the 10 practices in Eden. The workforce roles were pharmacists, pharmacy technicians, social prescribers, care coordinators, as well as working with our colleagues in community and social care. We've developed those roles to form the iCAT team. And in our first year, we decided that rather than start to visit patients immediately that the clinical workforce recognised in practice, we needed to identify the patients that weren't coming into practice, the patients that have an unmet need. Therefore, in the last year, the team have visited over 1,600 patients and undergone a comprehensive geriatric assessment. They've picked up lots of unmet needs, lots of loneliness, lots of people that are living in terrible conditions, and they have worked on behalf of those patients to get them into a better position.
Go out to see the patients and we do a care plan with a holistic approach to it, making the patient the centre of all that we discuss. We're looking at for their needs. For example, if the patient's struggling with mobility to get out of the property, is there where we could contact social services and see if they could fit a ramp for the patient. They were having trouble going up the stairs. We would contact social services to see if there's any funding available for a stair lift, anything like that. We also work very closely with all our other colleagues, like the occupational therapists, the physios, the memory team. We're in touch daily with loads of different other community services available. Social services are one of our main ports of call. We do a lot with them, a lot of referrals for care assessments, ongoing problems that they can support patients' needs and to keep them safe at home. We've now identified the patients that are moderate to severe, and they've become our virtual ward. So each care coordinator will have a list of patients that they're to look after. So anything that would be the mobility that had a number of falls, we will be contacted hopefully by the patient, and then we'd go out and see if there's anything we can assess them with. Are they needing a referral to OT or physio, anything like that we'd send them out to. It's a very rewarding job. It's every day is different, and I think that's what's the exciting thing about it. The team themselves, the girls themselves, are very enthusiastic and very caring. They just all seem to love their role and enjoy the role, enjoy the work. It's the variety which is very interesting, and meeting the patients. These patients, it's a pleasure when they let us into their homes to meet them one-to-one. It's an honour really, because they're letting us into their private space and open up to us, because we also look at the social side of it. There's a lot of social isolation in these rural areas, but there is a lot opening up now after COVID, and if we can support them to go to social events, even like a coffee morning in the local village hall, or the Fit for All are doing lots of services where you can go and do exercises. It's just getting the word out there that there's a lot of things that they could attend which would help them socially and also fulfill their lives so they'll have happy, safe lives at home.
Often the patients we see are struggling to manage the medication, so we'll go the other members of the team, the care coordinators, will highlight the patients to us who they can spot if they're visiting that they're struggling and they've got problems, and then we'll do either a joint visit with the care coordinator or a visit on our own with another pharmacist in our team, or we have a pharmacy technician as well. So we'll go and assess each individual medication and talk to the patient, build a relationship with the patient and try and help them solve any medication problems. Often patients are on a long list of medications which we call polypharmacy. They might have been on these for a long time and maybe some of the medications shouldn't be taken anymore, so we might actually stop medication. So we tend to stop more medication than we start. We had a particular patient who myself and Nikki, our lead care coordinator, social prescriber, went to visit, and there was medication all over her house. There was a bowl full of tablets that she was having delivered month after month by the pharmacy, and she hadn't been taking these tablets, and nobody had really spotted there was a problem. So we liaised with the GP and with the pharmacy and said, you know, that she's not taking this, she can't actually take it because of the special instructions this medication had. But nobody would have known otherwise if it hadn't been spotted by our care coordinator. So we visited a lovely gentleman who was taking medication to control his high blood pressure. But as he'd got older, the target blood pressure had got higher, as it does when you're following national guidance. So we wanted to review this, and the guidance suggests that they do a week's home blood pressure monitoring. The gentleman had dementia, so we enlisted the help of his daughter. We took a blood pressure monitor to her and gave her instructions and a recording chart. So she took his blood pressure for a week, and based on that we were able to reduce the dose of his blood pressure medication and then do a follow-up week's home recording again. So the benefit of that was it reduced the risk of falls, which can reduce the risk of fractures and dizziness, and also it saved the GP. We know it would have been a lot of time for the GP to go to do that.